Okay, so today we're going to be discussing dialysis. We're going to discuss the types of dialysis, the principles of dialysis. We're going to talk about peritoneal hemodialysis, CRRT, advantages and disadvantages of each type. So when we talk about dialysis is a technique that allows substances to move from the blood through a semi-permeable membrane into dialysis solution called dialysate. Okay, so that's just a general principle. It could be a man-made, it could be our peritoneal membrane, okay, but it's just a general definition, right? So the goal for dialysis overall is to correct fluid and electrolyte imbalances and to remove waste. We can treat drug overdoses with dialysis. Again, we're talking about the methods is peritoneal, hemodialysis. Those are the most popular people select, but we are going to also talk about CRRT, which is not like something that a patient would choose, but is done more of in an emergency. Okay, so dialysis, we said, is the movement of fluid and molecules across a semi-permeable membrane from one compartment to another. So fluids and particles move across the semi-permeable membrane. It replaces our renal function in a chronic and acute renal failure. So here's just a picture for you. This is your semi-permeable membrane picture. Okay. So generally, dialysis is usually begun when a patient's uremia is no longer treated conservatively. So they resort to dialysis. The principles of dialysis generally works by diffusion, osmosis, and ultrafiltration. And hopefully you've heard these terms before. This shouldn't be anything new for you guys, right? So diffusion is the movement of solutes from an area of a greater concentration to solutes to a lesser area of lesser concentration of solutes. Osmosis is movement of water from an area of lesser concentration of solutes to an area of greater concentration. And then ultrafiltration, the movement of solutes and water through a semi-permeable membrane by hydrostatic pressure. So it uses a pressure gradient. Okay? So the net effect is lowering the concentration in the blood of waste products, right? Of your creatinine, uric acid, electrolytes, all those items. You want to get rid of the waste products. Okay? Some things can move through membranes and some things are too big to move through membranes. Right, so we know red blood cells, white blood cells, plasma proteins, those are too big to diffuse through membranes typically, through the pores. So they don't come through. But the other smaller substances can pass through easily. Okay. So just a picture for you for the gradients. So when do we begin dialysis? Most nephrologists go by your GFR. Hopefully you've heard of what a GFR is, your glomerular filtration rate. Okay, and generally when that hits 15 is when dialysis is generally begun. So 15 mLs per minute per 1.73 meters square. Again, this can be vary depending on your nephrologist, and the nephrologist usually is following patients until they get to this point. And again, it depends on, you know, the clinical picture of the patient, signs and symptoms. If they're having, for example, like severe complications such as uremia, encephalopathy, neuropathy, uncontrolled hyperkalemia, pericarditis, accelerated hypertension. So if patients are presenting with any of these, they're likely going to begin dialysis. Okay? And these are more immediate need. So if their GFR isn't exactly 15, but they're presenting with all these symptoms or some of these symptoms, they may go forward and start dialysis. Okay. So most patients with end-stage renal disease are treated with dialysis due to the lack of donated organs. And we're going to talk about transplants in a little bit as well. But usually patients are going to stay on dialysis if there's no hope of recovery for their kidneys. Then they will be on a transplant list, and hopefully that will be an option for them. But we're going to talk about transplants, like I said, but a lot of people unfortunately die waiting before they get to the point where they can get a transplant. So we're going to start to talk about peritoneal dialysis. That's our first type of dialysis we're going to talk about today. And our peritoneal dialysis kind of started back in the 70s. And about 12% of patients receive peritoneal dialysis. So before we begin peritoneal dialysis, and that's just a picture of it, we're just going to discuss how it works, and they need to have a catheter placed for peritoneal dialysis, so they have to go through a surgical procedure initially. So for peritoneal dialysis, we use the peritoneal membrane as the semi-permeable membrane. And peritoneal dialysis uses the diffusion process to eliminate waste. So, and then of course we said that diffusion is the movement of solutes from an area of greater concentration to an area of lesser concentration. So we're lowering the amount, again, of urea, creatinine, uric acid, and electrolytes in the blood. And again, we're not going to be able to pass through red blood cells, white blood cells, and plasma proteins. They're too big to diffuse through the semi-permeable membrane. And I'll talk about a little bit more about the catheter placement insertion. Okay. So again, it's the client's own peritoneum. It serves as the semi-permeable membrane. So it's not man-made, it's your own membrane, right? And solutes move by diffusion in water. So this is just a picture showing you where the catheter goes into the peritoneum, and it's held in place by what's called a Dacron cuff. The catheter itself is called a Teckhoff catheter. Okay. Okay. So here's just another picture, like we showed you before, of the infusion process, the dialysate, and the drain. So it's going to go in through the bag, into the membrane, dwell for a little bit. We're going to talk about the phases, and then it's drained out into a bag. And here's your peritoneal catheter picture. So here I'm just going to let you know a little bit about catheter placement. It's accessed in through the anterior abdominal wall. It's a surgical procedure, so the consent is obtained. It's about 60 centimeters long, or about 24 inches. And again, it's held in place by a Dacron cuff. And that prevents the travel of microorganisms into the peritoneum. It takes time for the catheter to sort of settle into the tissue. It can take a few weeks. Fibrous tissue kind of grows around it, and then it kind of sets itself. The tip of the catheter rests in the peritoneal cavity, and it also has a lot of perforations, and that's how the catheter works. All those little holes in the catheter, that allows the fluid to go out and in. So before the surgical procedure, the only really thing that the patient really needs to do is empty their bowel and bladder. And you need to get consent and await. But once it's fully healed, patients can shower, just no baths. Okay. We're going to talk about teaching your patients what to watch out for. Yes, Marcus.
So this is temporary?
Peritoneal dialysis, it depends on the patient. For some, it depends on the uremic condition. It depends on the condition of the patient, what sort of renal problems they're having. But generally it's more of a permanent thing. If they're on a dialysis transplant, if they're a candidate for transplant, we're going to talk about that. But if they're not, then yeah, it can be a long-term thing and forever. Okay. So, like I said, it's anchored by the Dacron cuffs and placed in through the anterior abdominal wall. And those little holes or penetrations allow the fluid in and out. And the distal end is in the peritoneal cavity. So you can imagine there's complications. We're going to talk about some complications of the catheter and some other things with peritoneal dialysis. So again, they can shower. They just have to pat it dry. No baths. And education is really important to teach our patients undergoing peritoneal dialysis, as well as how to troubleshoot. Definitely, what do you think the biggest complication is with one of these catheters? Infection, absolutely. So we're going to teach them proper hand hygiene. Most of the infections are exit site infections, not from bacteria from the gut traveling. That's really rare. Normally it's exit site infections, so from microbes that are on our hands, as Staph epidermis, Staph aureus, those are the ones that are getting these patients. Okay, so we really got to focus on hand washing, cleanliness, hygiene, and teaching them signs and symptoms of infection. And you guys know what those are, right? Redness, swelling, temperature, drainage at the site. We're looking at the insertion site carefully. Good. And we're going to talk about signs and symptoms of peritonitis. We'll get there, don't worry. All right. So a little bit about the dialysate solution. It's usually these, have any of you guys ever seen it? So you know they're huge bags, okay? And generally they're maybe 1 to 2 liter bags. They may have one going at one time and have another one ready to go after. But generally they're high glucose concentrations. So you can see there's various concentrations they use. and electrolytes. So you know the glucose is going to pull out fluid. So that's why they use high concentrations, to bring the fluid out. And they warm it to body temperature. I don't know if you can see that. So ultrafiltration, it's using the glucose as the osmotic agent. Like I said, it's pulling, okay, with a pressure gradient. So we put the solution into the peritoneal space, and we call them exchanges. So we're going to talk about the exchanges. But here's a picture of the bag for you. Okay, so glucose is added to the dialysate, which creates an osmotic gradient across the membrane. This process aids in removing the fluid from the blood. So using ultrafiltration, that results when there's an osmotic gradient across the membrane. So that's how it works in a nutshell. So in peritoneal dialysis, the excess fluid is removed by increasing the osmolality of the dialysate with the addition of glucose. So all that means is that the glucose is pulling the water. Okay? So we're talking about exchanges. Bless you. All right. So sometimes they can take, there's a first phase of the exchange, which is the inflow phase. Occurs by placing the dialysis solution into the peritoneal space. And doesn't take too long to do. So they're pretty much emptying the bag into that peritoneal space in the first phase, right? And the second phase is we're going to let it sit there or dwell. And that's where equilibrium or exchange occurs. The diffusion and osmosis occur. And this is what takes time. So this can take from 20 minutes to 8 hours. Don't ask me why it varies so much. I'm not really sure. But I guess it depends on the patient, the size of the patient, but it can take a while. And then the third phase is the drain phase. And that's only 15 to 30 minutes. Sometimes the drain phase, and if it doesn't drain properly, it could be an issue where the patient, maybe the catheter kind of kinked or something like that, so you may have to change position or gently massage sometimes to help them pass it. And then the cycle starts again. So they'll do another 2 liters of fluid, and it keeps kind of going and going and going. So, and again, depending on the size of the person, they may use 2 liters, they may use 3 liters with each exchange. So it depends. Also on the patient's tolerance, if they have some other medical conditions, maybe like a hernia or pulmonary complications, they may vary. This time can vary. So we're going to talk about the complications as well. The nice thing is we can have it done while patients sleep at home. It's convenient. All these exchanges occur while we're fast asleep, which is pretty nice for patients. And they can kind of do it themselves if we teach them really well. It's pretty safe, not very expensive like hemodialysis. So a lot of advantages to it, to do that. Complications, of course, we have to be careful with some things, but we're going to talk about those things. So, advantages. We just talked about some. It's portable, can be done at home, and it's for people that are not candidates for vascular access. They may have exhausted all their vascular access. Some people are not always candidates for grafts and fistulas. When we talk about hemodialysis, I'll get into that a little more. So it's nice for people that don't have the ability to have a vascular access. It's less stress on the cardiovascular system. And you'll see why when we talk about hemodialysis. It's kind of a easier process on the cardiovascular system. It's not as much stress. It, of course, allows for travel, independence, a little more autonomy for patients. There's less dietary restrictions and greater mobility. So there's lots of good things. And again, like a lot of patients will have the option of choosing hemo or peritoneal dialysis. So this is a big reason why a lot of patients will opt for peritoneal dialysis. And of course, we talked about they can do it while they're sleeping. Of course, with everything, there are complications and there are disadvantages or risks, just like anything else. And there is a higher mortality rate after 2 years with peritoneal dialysis. So it's convenient, but you may be costing a price for convenience. And this setup is pretty simple for peritoneal dialysis as well. Complications. We're going to talk a little more about complications or risks. Of course, we talked about infection, especially peritonitis is a big one. Also, because of the glucose, we can wind up with hyperglycemia, hypertriglyceridemia from peritoneal dialysis as well. So we have to teach them to monitor their blood sugars. Weight gain, especially for women, weight gain is really a lot. So a lot of people don't want to deal with that, so they'll opt for hemodialysis because there is a tremendous amount of weight gain because you're letting it dwell in your body for so many hours and then drain. You feel just bloated and, you know, huge with all this fluid on board. So that a lot of people don't opt for that reason. So, plus potential protein loss. You can lose protein with peritoneal dialysis. Generally, like we talked about, the protein doesn't normally go through the semipermeable membrane. However, if there have been repeated infections, that membrane can become scarred after a while, and those pores get bigger, and you can spill more protein through. So you can lose a lot of protein with peritoneal dialysis. Generally, you're going to lose some smaller protein molecules, maybe 20 grams a day, but with repeated infections, you can lose up to 40 grams a day. And that may be a deal breaker for these patients. They may need to opt for hemodialysis at that point if they're getting to the point where they're becoming malnourished. They're not getting enough protein. Even trying to eat a lot of protein isn't going to make it sometimes. So it all depends on the situation of the patient. But yeah, that's a big problem is protein loss with peritoneal dialysis. And of course you have your catheter hanging out of your abdomen. So contraindications of peritoneal dialysis. Patients are not candidates if they've had multiple abdominal surgeries, if they've had severe pancreatitis, diverticulitis, any of those itises. A lot of abdominal or inguinal hernias, because that means your walls are weak. So you're putting all this fluid into weak walls, so that's not a good thing. Okay. Excessive obesity. Chronic back problems. As you can imagine, we're putting all this fluid and it's already going to burden your back. If you already have a bad back, it's going to add to it. and severe obstructive pulmonary disease. Does anybody know why that is? Yeah, that pushes up on the diaphragm, which is your lungs, right? So you're compromising your breathing. And if your breathing's already compromised, it will further exacerbate. A lot of people are going to say COPD exasperation. It's exacerbation. Okay. Right? Good. If I'm going too fast, let me know. Anybody need to go back a slide? Is that okay? I always try to watch and see who's writing still. Anybody get to see peritoneal dialysis in the hospitals? Yeah? Good. Yeah, it's interesting to see. You've had patients. Repeated infections, yeah. Yeah. And repeated infections is a bad thing, unfortunately. Okay. So there are different types of peritoneal dialysis. Okay. There's a continuous ambulatory peritoneal dialysis, which is CAPD. And these are manual exchanges, and they're usually done every few hours during the day. So a lot of people don't like this kind as much because it's during the day and people want to live their life. Unless they're like night people, this might not be a great option. And they do about 2 liters 4 times a day. You don't have to know exactly all this, what times they are and so forth, but just know about 4 times a day it's done. And so once the dwell is complete, they kind of disconnect for a while, and then they reconnect to allow drainage of the effluent, which is the stuff that comes out into the drainage bag. That's known as effluent, right? And then they keep hanging new 2-liter bags. Same concept. Okay. So they have a dwell time that's pretty long as well. It can be up to 10 hours. And that's a long time to be dwelling, right? And then there's automated APD, which is more desirable, more popular. So this is the type that they can do while they sleep. It's automated. That was that machine. That's your automated machine. It's called a cycler. And there are 4 to 8 exchanges a day. And about 1 to 2 hours each exchange. So in case things do go wrong with this while they're sleeping, there is alarms built in. So it really reassures them, makes it safe. And I've seen people with these machines, and they still have dialysis nurses in the facility that come in and check on them. So it's not like they're left on their own to do it all the time. They do have help. Thankfully for our dialysis nurses, they're wonderful. They do leave 1 exchange in the abdomen though, so you still are walking around with 2 liters in your stomach during the day. So they leave that, which is not always a nice thing. Like I said, for a lot of people that don't like that bloated feeling, peritoneal dialysis isn't always such a nice thing for folks. All right, we started to talk about complications, and the big one is exit site infections. All right, generally, like I said, it doesn't happen from the gut. It happens from dirty hands. Okay? And generally from Staph aureus, Staph epidermis. The normal flora of our skin can give us an infection. If we get run down, they seem innocent, but they're not so innocent, right? And again, we talked about the signs and symptoms: redness, tenderness, drainage. How do we treat? Antibiotics. If we don't treat, we can get tunneling wound infections. And some of you have been in the hospital and seen some of these, and they can be aggressive and very, very ugly. And they may need surgery. So tunneling wounds, which can cause peritonitis, and that results in catheter removal. So peritonitis, it's directly from contamination, from the exit site infection or one of these tunneling wounds. Again, most occur from improper technique, from touching the catheter and the site, right? So we really need to teach our patients and whoever's doing our exchanges when they're disconnecting and reconnecting that we use very, very strict aseptic technique. Because this is going directly into their abdomen. It's going to give them an infection if we're not very, very careful. So, signs and symptoms of peritonitis. What do you think our patient would complain about? Good. Abdominal pain. Very good. That's the big one. Abdominal pain, rebound tenderness. Our effluent that comes out is going to be what color? Cloudy. Good. It's going to be cloudy. And the way to confirm peritonitis, how do you think we confirm? Good. White blood cells. They will send a sample to microbiology and they will gram stain it and they will see a white count. If it's over 100 cells per ml or more than 50% neutrophils or positive gram stain, then we have an infection. And we are going to culture it, and sometimes it can take a few days to grow. Bacteria, like any other culture, it takes time. But we certainly are probably going to hit them with a broad spectrum antibiotic and make sure we treat the most common organisms, which are staph. Good. Epidermis, Staph aureus. Good. Okay, so GI, we talked about other issues. We may have some diarrhea, vomiting with peritonitis, abdominal distension, hyperactive bowel sounds. And they may have a fever, or they may not have a fever. Again, we confirm our peritonitis with cultures, and we can give our antibiotics. We can give them orally, intravenously, or intraperitoneally. Again, we talked about repeated infections. They can cause the membranes to scar, and they may wind up having to go to hemodialysis because of it. Another complication are hernias. So hernias are due to the increased abdominal pressures because all that fluid sits there. It's very common with women, multi-para women, and older men. What can we do for these? We can repair them. Surgery. And then they'll usually restart with a lower amount of volume. And they can keep the patient supine. It helps. Low back problems. We already kind of talked about, but it can happen because of the increased abdominal pressures. We can have a curvature, the lumbar spine, because of all the fluid that we're putting in there. It just causes pressure. What can we do for these? Any ideas? Sometimes we can give them a binder, like an abdominal binder. We want to strengthen those back muscles. So anybody that has bad backs, we want to put them in an exercise program, do some cardio, and get that back strong. Other complications are bleeding. It's normal to have a little bit of blood after the initial insertion of the catheter. You may see some pink tinge, but otherwise it should be clear. Sometimes when women are menstruating, and I'm again not exactly how this happens, but it can be pink tinged because women are menstruating. But other than that, it should be clear. There should not be any blood. And if there is blood, that can mean there's an intraperitoneal bleed, and that this patient can bleed a lot if there is blood. So it could be a tear in there, something, maybe they pulled something, maybe it ripped. Hard to say from what, but it can happen. It's rare, but can happen. And if this happens, we could wind up going into hypovolemic shock. So we're going to test their hemoglobin, hematocrit, right, and look for those things. Especially if you notice the drainage is bright red. You know there's a bleed. This is something that we don't take lightly. We get them in the hospital. We treat it immediately. Pulmonary complications. Again, we talked about the pressure exerting on the diaphragm. So what kind of complications, breathing complications, do you think we are prone to for these folks? What's that? Yeah, shortness of breath, but because they can't really take deep breaths, what complication would you expect? Atelectasis, I heard. Did I hear that?
Yeah.
Atelectasis, right? Because they can't really open the bottom of their lung because all that pressure is pushing up on them. Plus, they can get pneumonia. So they're very prone to pneumonia because of all that volume. So what can we do for these guys? Good. Deep breathing. Reposition them. Maybe sit them up if they can tolerate it. We'll put their head of the bed up. That will help alleviate some of the pressure on the diaphragm. We can give them an incentive spirometer to help prevent pneumonia. And reposition a lot. Protein loss we talked about. We are going to lose some protein. So we may lose some protein in the form of amino acids and polypeptides, right? And they're lost in the dialysate fluid. Like I said, normally we can lose 10 to 20 grams a day. Again, with infection, it can go up to 40 grams a day, which is a lot. And as that membrane becomes more permeable, we're going to lose more and more protein. Again, unresolved peritonitis can lead to too much protein loss and malnutrition. So we may have to, this may be a cause to stop the peritoneal dialysis if we can't fix it. And that's one thing that's really difficult, to get a lot of protein into some patients. And I know there's a chart in your book that kind of goes into the peritoneal advantages and disadvantages. I think I put it on my notes. I can't remember which page it is. 1085, thank you. So definitely review those charts in your books for complications of peritoneal versus hemo versus transplants. So solutions we already kind of talked about, but real quick, peritonitis, we're going to make sure we're aseptic. Watching for a cloudy effluent. Sometimes if a patient is very constipated and they have a full colon, that can block the catheter. So sometimes we can give them a laxative as well to resolve that problem. Bleeding, again, we're monitoring the drainage, our abdomen, our labs. Hernias, we said surgical repair. Pulmonary, deep breathing, head of the bed up. Our back, we're going to binder and exercise. And don't forget our blood sugars. We can avoid hyperglycemia if we're pretty consistent with our dwell times. We're not doing it all different times of the day. It kind of helps. And protein loss, not much we can prevent it, but we can try to add more protein in our diet. We talked about signs of peritonitis or infection. Our cloudy effluent, our white blood cells greater than 100 cells per ml, 50% neutrophils, positive blood culture by gram stain. And if we have too many infections, we may need to terminate. Any questions with peritoneal dialysis? Pretty straightforward, right? All this is in your textbook. Please fill out your modules. That will really help you with this, especially with like complications and advantages, disadvantages. Focus on those. So we're going to go ahead and get into hemodialysis. Okay. So if hemodialysis does not work, or is contraindication, peritoneal dialysis doesn't work, or is contraindicated, then especially like in an emergency, we may need to opt for hemodialysis. To do hemodialysis, we must have an access. And these can be done pretty quickly. We can put in a temporary catheter. So if we need to immediately dialyze somebody, this is really the likely the only option, either a hemo or CRT, which we're going to talk about. So so we need a vascular access that has a large vessel, using a large vessel. And these are required for rapid blood flow, rapid exchange. Again, we can do a temporary, or we can do like a long-term catheter with a cuffed catheter. But they're generally, long-term catheters are cuffed and anchored. But some are temporary, like the Quinton catheter is a temporary catheter. They're usually, has anybody ever seen a catheter for dialysis? They're not the same as central lines. Be very careful. These are usually a red port and a blue port. And we don't touch them. We're going to talk about the care of them. But generally, our dialysis nurses are the only ones that really are permitted to use them. But we're going to talk about that a little more. So here's a couple pictures of your dialysis catheter. And they're using a large vessel, so it's required for rapid blood flow. So usually they're planted in the subclavian, right or left. Again, not everybody's a candidate for this. Some people don't have really good vascular access sites. Temporary ones are the Quinton catheter. Some are Kendall or Hickman, and those are tunneled. We do not use these. Like I said, we do not use these to give medication or to draw blood, or only the dialysis nurses will be caring for them. Because we put in, the dialysis nurses will be putting in a significant amount of heparin. And if we were to use these catheters and use them and flush them, we'd flush away the heparin and potentially cause a clot to occur, and then these catheters would be no good anymore. So that's why we're not to touch them as regular nurses on a unit, a med-surg unit. We only let our dialysis nurses care for them. If the dressing became loose or soiled, or blood underneath it, then yes, we can change the dressing. But that's all we can do, is just change that central line dressing. Oops, sorry, did you take a picture? Okay. Next, we're going to talk about more permanent access, which are your AV fistulas or your AV grafts. So arterial venous. So what this means is an anastomosis, which means they take a vein, they take an artery, and they sew it together. It takes time for it to mature. 4 to 6 weeks. So it's a fistula is, bless you, a natural way to anastomose the vein. Okay? It's usually in the upper forearm. And they use a basilic or the cephalic vein to do this. So the fistula allows blood to flow through the vein. As the vein becomes arterialized, it increases in size and the wall gets thicker. Have you guys ever seen these veins? They look like they're almost bulging, like they're so big and fat. And it's amazing what our body does. But this allows it to get tougher. It needs to be tough because it has so much rapid exchange. And that's what's essential for that rapid blood flow for hemodialysis. So as the fistula matures, it gets easier and more amenable to constant venipunctures. So it's amazing what our bodies do. It like tolerates being stuck constantly. And our patients do get used to it. So again, it takes a while for it to mature. So how do we check these to make sure they're working? Yes, auscultate for brewing. Good. And then we listen for a thrill, right? So that means like there's a buzzing sensation, right? So the thrill can be palpated if you touch it. It's kind of like a swishing sound. Kind of reminds me of when I was pregnant. You hear the sonogram, you hear that swish, swish, swish. So kind of the same kind of a sound. And then, so you can feel the thrill and listen with your stethoscopes, you'll hear the bruit. So these ones are pretty good. The fistulas are good for patients that have peripheral vascular disease, diabetes. Sometimes if they've been drug abusers, these are a better option than the grafts. So the grafts, the AV arteriovenal grafts, are a little bit different. They kind of do the same thing, but they do it made from a Teflon, which is an artificial synthetic material. They put a graft in your arm between the arterial and venous blood supplies. So it's a surgical procedure, usually done in the arm and the antecubital. And these again take a while to mature and heal, 2 to 4 weeks. So it's a little quicker than the fistula.
You said these are better for drug abusers?
Yeah, sometimes
How do they even, usually drug abusers beat their veins up so bad, like how?
So that's why they would have to have the synthetic part, because their veins are no good.
Yeah, I mean, you can't even get blood from them.
That's why you would do the graft versus the fistula.
I mean, do they like clean the veins out in order to make the graft? Because if they have bad veins, how can they make a graft?
They may, They may use some other device, but that's why they use the artificial device instead.
Are they assessed the same way, the buoy and the thrill?
Yes, they are. Mm-hmm. Good question. So, but they do heal quicker, but they artificial. So, complications. What do you think we would see with complications with anything synthetic? Infection, yeah, but also what happens when we have a foreign body infection, yeah, definitely. Also, clots. Our platelets like to stick to them, right? So they're prone to thrombosis. So that's why you're definitely going to listen for your bruit and your thrill, because these kind are prone to clots. They can be very thrombogenic. And they're more prone to infection also, you're right. And usually if they do get infected, you have to take them out because it's really hard to treat an infection with something that's foreign. Usually the only treatment is to remove it. So just the picture of those. Okay, any questions with fistulas or grafts? Okay. So when you talk about the principles of hemodialysis, it is done with an artificial membrane. So it's different than peritoneal dialysis because it uses an artificial, like a cartridge looking kind of thing. It's made of like a synthetic material, and that's your semi-permeable membrane. And that comes in contact with the patient's blood. And then the gradient is created by increasing the pressure in the compartments, like a positive pressure, or by decreasing the pressure in the dialysate compartment, a negative pressure. So our extracellular fluid moves into the dialysate because of the pressure gradient. So excess fluid is removed by creating a pressure differential between the blood and the dialysate solution. Okay, so it kind of works in the same sort of way, but artificially. So our dialyzer has like fibers, and that's where the exchange kind of occurs. The dialysate is pumped into the cartridge, bathes in the fibers, and ultrafiltration and diffusion and osmosis occur across the fibers, which is your semi-permeable membrane. And then once it's clean, the clean blood kind of loops around and goes back into the patient once it's clean. And here's kind of a cycle picture you can kind of see. So your dialyzer is like this big hollow cartridge, and it's in the middle of it is all these little fibers, and that's what is your semi-permeable membrane. And it pumps the blood through these fibers, cleans the blood, and then brings it kind of back full circle. Okay. It's just a picture of one of your catheters. And your grafts. Okay. So the procedure of dialysis, we have our large bore needles. I'm going to post a video if you guys want to watch it, but our large bore needles are inserted into the fistula or the graft site, and that gives us our vascular access. So we have one needle that's used to pull the blood from the circulation into the dialysis machine, and the other is to return the blood to the dialyzed blood back into the patient, like we said. So you have these two accesses in your arm, whether it's a graft or a fistula, there's two needles in there. And when you use a catheter, it's just your lumens. One's red and one's blue. Okay, so the red one is the one that pulls the blood, and then the blue returns it. So when the blood hits the dialyzer, that's when they add heparin, and they can add it in directly into the machine. I'm going to go back a slide. Okay. And they use saline solution to return the blood back to the patient. Once it's finished and the process is complete, the dialysis nurse will apply firm pressure when she removes those needles. He or she removes the needles until bleeding stops. So this is one of the areas where bleeding can become a problem. They have to put because it's going right into an artery. So once you remove those needles, you can bleed. So they sometimes will use clamps. I don't know if you've ever seen them, but they will use some clamps and apply pressure. Right? Okay. So before dialysis, let me just do this. Let me just see one thing. Oh, here's a picture of your cartridges. Okay. That's what they look like. And I just wanted to let you know also an important thing with AV fistula complications. You can get what's called Steele syndrome. Have any of you ever heard of it? What it indicates is that the blood is being stolen away. So you have no circulation distal to the fistula. So your hand becomes tingling, painful, cold, and icy. And so you have arterial insufficiency for that hand. So it's painful, cold, distal to the fistula. That's called Steele syndrome. And that needs to be reported to the surgeon or the provider, because the only way to fix it is surgery. So Steele syndrome. Okay. I'm going to post the videos for dialysis if you're interested in watching them. It just shows you the process.
Does that Steele syndrome, can it happen at any time? Or is this like only in the beginning stages, really?
It can happen anytime, from what I'm understanding. Sometimes after dialysis, you know, once the process is done, or during dialysis, it can happen because you're pulling off the blood, you know. So, but it can happen anytime. So just like with peritoneal dialysis, there's advantages and disadvantages. But first, before I talk about that, I wanted to, nursing management. Okay, next is nursing management. So advantages, again, it can be immediate relief of symptoms. It can prevent complications. We can remove the fluid rapidly and waste products rapidly. And a lot of people like it because they don't have to worry about doing all the stuff they have to do with peritoneal dialysis. So they prefer someone else to do it for them. It depends on your type of patient that you're dealing with, you know, whatever works best with their lifestyle. And again, we can do a temporary access at the bedside, which is always a really good thing. We can do it immediately. And there are cases where some people do home dialysis, but it's kind of rare. Most people will go to a facility, like an outpatient dialysis center. Disadvantages, of course. What do you think the biggest complication with hemodialysis is? What's that? Clots. Hypotension. Clots too, but because we put heparin in the machines, it's not as big of a complication, but it can happen. But and the machine can clot, yeah. But the biggest complication, and I would certainly no. Yes, because we're taking off. Think of your massive amounts of fluid shifts in the body. We're taking all this fluid off very quickly. And before they get dialysis, a couple days goes by, right? Maybe we have Monday, Wednesday, Friday schedule. Maybe we have Tuesday, Thursday, Saturday schedule. Before that schedule comes up and they're due, they're overloaded, right? So they've got too much volume on board. And then we massively take it off. So the biggest complication with hemodialysis is hypotension or hypovolemia. Anemia. Why do you think anemia?
You're taking everything out there.
Through the machine, it gets destroyed. A lot of those red blood cells can get destroyed just because of the machine. In the process, they do. So they need frequent blood transfusions. So typically, one of the risks are, because of the multiple blood transfusions, they are prone to blood-borne pathogens, such as hepatitis. We can give vaccines for Hep B, but not for Hep C. So you will frequently see a lot of these patients have Hep C. And then, of course, there's 20 other blood-borne pathogens that these folks are prone to, including HIV, all those other things. So, anemia. Oh, side effects. Sorry, side effects. My abbreviations. Muscle cramps can happen. They're not really sure why, but it's likely because of the massive fluid shifts. Yes? If they want to live, yeah.
Because it says, like, for like kidney transplant, it says like the blood transfusions are contraindicated, not contraindicated, but it's something called like antibodies, and it'll less of a chance of getting a transplant.
Down the road, you mean?
Yeah.
Yeah, once you get frequent blood transfusions, I think what you're saying is you build up more antibodies.
Right, yeah.
So yeah, that can be a problem. But what they do with those folks, and with every dialysis patient, which is very common, all these patients are getting multiple transfusions. We're going to talk about transplants, but what they do is they give them plasmapheresis. And we'll talk about that when we do HLA matching and so forth. But yeah, you're right. And when the more transfusions you get, the more antibodies build up. Absolutely. And the more prone you are to reactions and rejection from organs, for sure. That's very true. It's a good point. All right. And we talked about heparin. So we have to make sure we have good amount of platelets, right? So we have to be really careful if our patient starts getting that HIT, heparin-induced thrombocytopenia. So some patients do get that, so we just have to be watchful. And again, we have surgery, again, for vascular access. Even if it's a temporary catheter, it's still a procedure. So again, all those complications, we need to have strict, sterile, aseptic technique. Good. So pre-dialysis, what do you think we would want to do? Weigh them. Thank you. We have to weigh them because that's the only way our nephrologist is going to know how much fluid to take off. So they weigh them before dialysis and they weigh them after dialysis. Very important. And of course we do the rest of our vital signs because we talked about the massive pull, all that fluid coming off, right? We got to take all that fluid off to get rid of the waste. So we're losing all our volume. So before dialysis, we are going to hold our blood pressure medications. A lot of times they get dialyzed out anyway, so, but you're already taking off all this fluid. That's the whole point of dialysis, is to remove the fluid and all your waste products. So if you lose all this fluid, you're gonna bottom out your blood pressure. And you're gonna be hypovolemic when you get back. That's almost expected. So we're monitoring for edema, our blood pressure, intake and output, because some of these patients can still urinate. So, so we're going to do that as nursing, pre and post. And I always communicate with my dialysis nurse. Let them know antibiotics, sometimes they'll give it towards the end of the treatment because they're dialyzed out too. And different medications can be held. Okay. So we got to watch our skin, auscultate our heart and lung sounds. Like I said, we're watching for overload before they go to dialysis, right? And I'll tell you a quick story. I had a patient once who came back from surgery, and he came from PACU. The PACU nurse brought him up, and they put in the graft site. He had a temporary, and his surgery was the graft. But there was a liter of fluid that only had a couple drops left in it. And I will tell you, the PACU nurse let a whole bag of fluid go into a dialysis patient. So when I got him back, he was 200 over 100 blood pressure, JVD, chest pain, sweating, in distress. And I asked the nurse, is this, you let a whole bag of fluid go in? And she said, yeah. And there's nothing you can really do. You can't give him a diuretic, right? So I had to call stat dialysis. That was the only way to treat it, to get the fluid off. So it's really amazing how much a fluid volume with these patients can really make a difference. And you have to have your eyes open and be alert. Yes? It's up to the doctor. It depends on their serum sodium levels. Some are, some aren't. That's a good question. Yeah, it's possible. Not everybody is. They don't encourage fluids, but they don't always put them on a restriction. But yeah, but you do have to watch the amount of fluids you take in for sure. So, but anyway, he was okay. They dialyzed him, and he turned out to be fine. But if I wasn't on my toes and somebody was, just let the patient be, that person would have certainly gone into failure. The heart can't only take so much, So, what would you do in nursing management? I don't have it on here, but think of the massive fluid shifts, electrolytes pulling off. What could happen to your patient? What's a big complication? Yeah. Good. Dysrhythmias, yes. Because of all the fluid, you're taking off all that fluid and you're moving all your waste products, and you're going to have severe changes in your electrolytes, your sodium, your potassium. So yes, you're prone to cardiac arrhythmias. So these folks need to be on telemetry. Yeah, you could treat the rhythm if they go into a bad rhythm, but you're going to watch for that. Replace your electrolytes if they need it, absolutely.
You have to stop dialysis in order, otherwise you're just wasting medication. Is that not accurate?
Yeah, because it gets dialyzed out anyway. So, but yeah, you can replace some of the potassium. That's why you do labs before dialysis, so you know what they are going in. And they don't always recheck them, but after they pull off the fluid, they may check them. But that's why during dialysis, because of the exchange, you want to have them on a heart monitor. And you're watching their skin, of course, their access site, temperature, vital signs. Okay. Another complication is called disequilibrium syndrome. And this kind of mimics the fluid on the brain, your cells swell, and signs and symptoms. And it's due to the fluid shifts. This is a complication that can happen. It's not very common, but it can happen. It's kind of like there's a cerebrospinal fluid. The fluid gets trapped in the brain, and it causes, because of the fluid shifts, and it causes cerebral edema. Signs and symptoms, of course, confusion, restlessness, headaches, seizures even. And this is pretty common with dialysis patients, believe it or not. So sometimes they won't treat it. Sometimes they'll slow it down depending on how bad it is. And they may even give a hypertonic solution to help draw out the fluid of the cell. Yes. It's not in the book?
It's not even in the index. I'm looking right now.
Oh, really?
I don't see it either.
Well, it's a nice to know then. I don't remember it not being in the book. I'll have to find it for you because I thought it was in the book, but it's not in there. Okay.
I'm looking in the index right now and I don't.
Okay. Well, I wouldn't say commit it to memorization then, but just so you know that can happen, and it's a good to know. But yeah, I'm not sure why it's not in there because it is a complication, for sure. But thank you for telling me. I'll look it up and see. Okay. What's that?
I said I started to panic. I'm like,
Oh, sorry. I didn't mean to freak you out. Okay. So for dialysis, we just want to make sure we're checking our weight, our blood pressures, and our labs. And generally, people get hemodialysis 3 to 5 hours, 3 times a week, like we talked about. They prime the machine with saline. Again, they use heparin to prevent clotting in the machine. The blood, this isn't nice to know. I wouldn't commit this to memorization or anything, but it's pumped about 200 to 500 mLs per minute. And the dialysis sate is also pumped about 300 to 900 mLs per minute. But that's why our nurses are checking the vital signs every 15 minutes during dialysis. Okay. Again, watch for hypovolemia, and we want them on telemetry. So, nutrition. This is in your books. I'm not going to go over this too much. But just know, like I said, we have to watch the fluid with dialysis, hemodialysis. You don't want to do more than urine output plus 600 to 1,000, depending on the size of the patient. Some, like we talked about, will put them on a fluid restriction, some won't. But they will tell them to watch their fluid intake. With peritoneal dialysis, there is no fluid restriction. Protein intake is almost the same, because you do lose some protein during dialysis, hemodialysis too. You will lose some, so you can have a little bit more. I know in end-stage renal disease, before they get to hemodialysis, they restrict the protein on the kidneys. But now we can give a little back, okay? Calories is about the same, depending on the size of the patient. But with peritoneal, we do want to watch our blood sugars. So we're going to kind of do a carb control a little bit more. And sodium is almost the same. Potassium is not restricted with peritoneal dialysis. And our phos is about the same. So think about your food intake. You're not going to give a dialysis patient foods that are high in potassium. What would examples of those be? Potatoes, good. Bananas, cantaloupe, yeah, melon, good. And what's in phosphorus? Dairy, good. All right. Okay, I'm going to give you a break. I'm going to stop here.